Hi there, my name is Courtney. I am a PA. I've been practicing for the past 10 years. I founded empoweredpas.com, which just started as a blog and has really morphed into a resource for PAs, pre-PAs, and PA students to learn more about the profession and learn about opportunities that exist out there for practicing PAs especially. It's one of the things I love to talk about. It's kind of the thing I'm really passionate about. In fact, we've got a lot of articles already up there about that. But my friend Michelle and I, she has an article up, you should definitely take a look at that. She's an MSL. We were talking and she had a great idea, which is that we should put a little video together showing you guys what the different roles PAs can hold in a non-clinical setting. And so that can be a wide variety of things. But I want to share that with you. Thank you to Michelle for putting this together. I'll talk about my role in a minute, but just wanted to introduce you to what we're going to be talking about.
Hi, my name is Christy Delcamp, and I am currently working in a non-clinical PA position as a sub-investigator at a clinical research facility. We run phase 2 and 3 trials for new drugs and vaccines that are coming to the market. My background's in emergency medicine, so a lot of my comparisons will be to that. So I would say the main difference in emergency medicine and clinical research is in emergency medicine, you're running room to room, you're seeing, patients back to back, you're performing a lot of procedures, ordering a lot of diagnostic testing, and in clinical research, we will perform some physical exams if the protocol calls for it. But for the most part, we are just determining if these patients are eligible to enter our clinical trials based on a set of protocol inclusion and exclusion criteria, gathering their past medical history, and so forth, medications. From time to time, we will do a physical exam on a patient and find something concerning. Our job's not to diagnose it there. Our job's to send them back to their primary care doctor so they can have a workup and kind of go from there. So the second point is the quality of life. This is a more 9-to-5 job. I had a lot of trouble in the beginning deciding whether I would be able to give up those days off from the emergency room, time with my kids and so on. I have 3 little kids, and now I'm home every night for bedtime. I don't work weekends, no holidays. There are a lot of additional benefits that my particular employer in the emergency department did not provide, such as paid maternity leave, which I've gotten with this company, which has been fantastic. And speaking of compensation, the compensation, again, going into a more office role, more 9-to-5, most people think that they're going to take a pay cut, but in reality, the pay from the ERs where I live and in comparison to what I'm making at the clinical research facility are very similar. With the additional benefits that I wasn't getting, I would say that they're right on par. Currently, I'm only working 30 hours a week, which has been a great thing for my family. I've been able to cut back and be home a little bit more with the ability to go up to 40 hours when I'm ready for that. In addition, within my particular company, and I believe most of them, there are room for upward mobility, which is a nice place to be because in the emergency department, you are what you are, and that's great. But if you want to, move up and do anything more, there's not that room. But within my company, you can move up to more senior leadership roles if that's what you're interested in. I would say overall for my family, it's been a really great move. It wasn't something that I initially thought I would be interested in. When I took the position, it was an 8-week assignment for a vaccine trial, and this extended into a full-time position that I'm very happy with. I've learned a lot. There is a huge learning curve going into clinical research, but I would say that overall I've been very happy. I don't miss the procedure part of it. Some drugs that come to us that we're doing trials on do have things like punch biopsies. They do have things like, some pelvic exams. So you do get a little tiny bit of the procedure world, but for me it was a small price to pay to be able to have more flexibility in my family and be home more. Please reach out if you have any questions.
Hi, my name is Jean Kelly, and I'm one of the physician assistants at Rochester Clinical Research. Although our job is not technically considered clinical, as we do not diagnose or treat patients at RCR, the physician assistants that work there are required to have medical experience and medical knowledge in a vast array of conditions. Our titles are technically called sub-investigators, which means we represent the studies as medical providers and evaluate that trial subjects meet the inclusion and exclusion criteria set by the trials. We must be able to recognize medical conditions that are exclusionary and perform physicals on each patient to confirm their ability to proceed with the trial. We discuss potential side effects of the product, risks versus benefits, and ensure that the patient is able to consent safely and understands what is required of them to continue with the trial. We also follow patients throughout the trials. For example, if there's a COVID vaccine trial and a patient calls with symptoms concerning for COVID, it's our responsibility to talk to the patient, give them a call, bring them in for a sick visit if their symptoms are concerning enough, where we will take another history, perform a physical, do a nasal swab, and guide the patient, although we would not give them formal diagnosis or treatment. We may also evaluate patients' medical records if they're ever hospitalized throughout the study, and in conjunction with the primary investigator or the MD, we would deem whether or not this hospitalization was related to the investigational product that they received. Overall, the safety of the patients and of the trial relies a lot on the physician assistants that see them, as we are the main safety barrier before they receive the investigational product.
Hello, everybody. My name is Sarah Gino, and I am a physician assistant in clinical research. I was a PA in primary care for about 17, 18 years when I made the transition, and I've now been in clinical research for 2 years. I work in Rochester, New York at a private clinical research facility named Rochester Clinical Research. And we do all sorts of different clinical trials, all different phases, mostly vaccine studies, but also migraine, weight loss, quitting smoking, and other medications. If you're considering research, I didn't know that it was an option for a PA. It was something I didn't have much exposure to. So when the opportunity was there from a mutual internal med provider, spoke well of it. I said, hey, let's give it a try. I didn't think I could do it, didn't think I had the right background, but it's worked out beautifully. So if you're interested, there are some great YouTube channels. There's a guy called the Clinical Trials Guru. And I'm going to share the screen and show you. His name is Dan, I think Farah or Sarah, and hopefully you can see it. The Clinical Trials Guru, and he talks and explains all about clinical trials 101 in very lay terms, easy to understand. So that's where I would say to start, just learning what is involved in clinical trials. And if you're thinking you want to go one step further and maybe take some free courses or get some certifications, the Association of Clinical Research Professionals is great. They have lots of free courses, some of the required courses for professionals in research, and then certification programs for research professionals, research assistants, study coordinators, and investigators. So if you're thinking about research, you could try looking at these places, looking at your university-based hospitals. There's a lot of research done inpatient for HIV, oncology, GI, cardiac devices. I know APPs are often involved in hospital settings. Outpatient, I think the best way would be to kind of research where patients go for clinical trials, and then look at, do they hire PAs? So let's see. All right, I'm going to stop sharing that. As far as the roles in a hospital setting, research quite often, either an RN or an APP will kind of act as a project manager, everything from communications with the sponsors, the IRB, who's the third party who watches over and checks our charting, making sure you're ethical and doing everything correctly, to recruiting patients, treating them, screening them. So in the hospital, one person may do every step. In outpatient research, PAs especially, we tend to be a little more hands-off. Our registered nurses will act more as project managers, and the PA will be more involved at the screening visits, randomization or injection or drug investigational product visits. And if something comes up like an adverse event, we'll get more involved there in a clinical sense. In our facility, we have a whole research or a recruitment department. Our nurses act as program managers. And so the investigators have minimal contact with patients. And my colleague, Jean Kelly, has created a second video that does talk about the bit of clinical that we do with patients. Other ways in which we spend our day in clinical research, we have to train a lot of staff. We have to be there to answer all the clinical questions, having that higher executive thinking to determine if someone is the right candidate that can be allowed in the study and won't affect the overall objective and what this study in the phase that it's in is looking for. Sometimes we have to sit with the president of the company and marketing, make sure all their marketing is correct medically. The president isn't medical, so we'll give him some advice on feasibility. Do these patients really exist? Help interpret protocols because they're not always, they're written by people who English is not always their first language. And so there could be a major difference between a comma, an and, or an or. We'll review blood work. We'll advise on the ethics of things. And so it is kind of nice. I would say the pros of clinical research would be you get a little bit more desk time. It's a slower pace, especially for outpatient, inpatient, like cardiac device testing. That's going to be pretty intense, much faster paced. And I've never done it myself, but an NP that I work with has. So it's great. We still get to do a little bit of patient contact, but it is nice to have a break and mix up your day, use your brain in a totally different way. The team aspect I really like. You're working with everyone within a company. The cons of clinical research, I would say, is that sometimes I do miss having a little bit more patient interaction where you feel like you're making a difference right away. Where in clinical research, you're still making a huge impact, a great difference, but it's just more behind the scenes. When Ebola was going on, our research was working on the vaccine. And so it's kind of neat to know that, that is over in Africa being used now. You don't get to see the benefit, but you can hear about it. The COVID vaccine trials, we've been on the Pfizer, J&J, Novavax, all the way through. That's probably the closest we've had to kind of instant gratification of making a difference, because it was going on as we were doing it and very quickly but thoroughly. So that's basically it. And then, like I said, there will be a second short video for my colleague Jean Kelly talking about the clinical part, if anyone's interested. You're certainly welcome to reach out to me at Rochester Clinical Research or sgeno, Geno, at rcrclinical.com. I'd be happy to answer any questions that I can. I just kind of fell into this job. Most of the time, I don't believe you have to be certified or have a research background. But it doesn't hurt to take some of these courses and look up things, of course. So good luck. Thanks for having me.